gears again a little bit here and finish our symposium off today with, again, primary women's issues, and no better to talk about these issues than is an OBGYN physician. We're very fortunate to have speaking today and also to be part of Northern California Medical Associates in our OBGYN section, newly added at the end of last year. Dr. Shazah Khawaja. No, she's not an indie movie star, but she looks like one. And she's going to talk to us today about dealing with OBGYN cancer. She received her medical degree from Ross University and subsequent training in New York and various places, ending up at the Brooklyn Hospital Center as the chief president. And she is a fellow of the American College of Obstetrics and Gynecology. She's here. Okay, join me in welcoming Shazah Khawaja.
First of all, I'd like to thank all of you for giving me the opportunity to speak to all of you. It'd be lovely to actually put a face with the names. Thank you for your referrals, and thanks for making women's OBGYN a part of the NCMA family. Okay. Hereditary cancer risk assessment. The standard of care is upon us, or tackling cancer one woman at a time. That's basically the focus of my talk. I know it's been a long day, but I'm going to try to keep it short and sweet and just get some take-home messages that you will consider pretty important and straightforward. Why am I here? Well, ladies and gentlemen, as you know and have realized in life, that usually there's one catalytic event or occurrence that basically paves a path that lets you know that you can make a difference. And this battle can be actively fought every day on a daily basis. This battle was one that I also undertook. My grandmother was an obstetrician gynecologist in Pakistan. And unfortunately, she had died at the mere age of 45 from primary breast cancer with metastases. I was unfortunately never blessed to actually meet her, but she was a remarkable woman in my lineage. Nonetheless, stories of her service in women's health laid a foundation in my heart to do the same someday. Hence, here's my passion for screening for hereditary breast ovarian cancer and Lynch syndrome. Why are you here? Well, if there's one take-home message that I can impress upon you as my fellow colleagues, is that YES, yes, I can screen for these cancers in my office. And most importantly, I can do it in a timely fashion and deliver the care and options of screening to my patients, maybe not just once a week or once a month, but every day in my practice. Okay. Here are some dangerous myths or misconceptions that we don't need to know. Our patients don't want to know. Someone else can do this better than we can. My practice is too busy for this. All tests are the same. Okay, so basically, how many patients are we talking about? Hereditary cancer risk assessment is just as important and not different from what you're probably already doing in your office. You screen patients for family history. You evaluate a positive family history. You diagnose by a screening test and manage according to either a negative or positive diagnosis. Okay. Do I need this information? Okay, so let's start off with a case. This is an actual case of Allison. This family history is actually not that unique. For instance, mother with breast cancer at 45, maternal aunt breast cancer at 52, paternal aunt breast cancer at 50. What questions are you left with? Can you guess what is this woman's actual risk? What's the take-home message on this busy slide? Basically, this is about risk stratification, positive or negative. These are the risks. So one can ascertain that the general population from the familial bucket risk, you can ascertain that by taking a family history. However, how do you ascertain a risk or a difference between familial risk and hereditary risk? The only way is that you need to do a diagnostic workup. Going back to Allison, we get a negative BRCA result. A negative result is actually quite significant. Using an actual risk model, one no longer guesses on a woman's risk. It allows you to follow up with a preventative MRI, with a mammogram, and a twice-yearly breast clinical exam. What happens if she's positive? Well, it's a different ballgame. Everything changes, and obviously that would be your most at-risk patient. But again, you can't tell any of this without an actual result. Okay. This is actually in one of my patients. Okay, so this is, why do we do a breast MRI? If you have 7 patients with a strong family history of breast cancer and you have a BRCA negative and mammogram negative, you can have a screening MRI that comes up with invasive breast cancer. Okay. Guidelines for familial breast cancer. We always want to know, cost is a big issue. MRIs, are they covered? Well, now there's national recommendations that a screening MRI is recommended for women with an approximately 20 to 25% greater lifetime risk of breast cancer, including women with a strong family history of breast or ovarian. Again, this is the American College of Obstetrics and Gynecology, again, reinforcing the same guidelines. Insurance companies, we have to battle them, but these guidelines are out there so that we do get approvals for our patients. The NCCN. The NCCN is regarded as the gold standard for treatment, detection, and prevention, and also supports screening through MRIs. This is another case. This is a patient that was known for 12 years. Now this was interesting. So she's a 38-year-old, para 2, she presented for her first OB appointment, and she had a family history of paternal grandmother with ovarian cancer at 63. Okay, so the main point here is that ovarian cancer can either be in a first or second degree relative, and it meets criteria at any age. This patient was BRCA positive. So a simple family history that you probably wouldn't think of implies huge risks of breast and ovarian cancer. Management changes dramatically because surgical options of prophylactic surgery come into play. Okay, so on this slide, basically as a primary care physician, here's basically what you need to know. You need to employ increased surveillance, possible chemotherapy, and prophylactic surgeries. Or you can refer out. I'm part of the NICMA family now. Don't let the potential of getting a positive result deter you from doing a diagnostic workup. These are real risks which are in our communities and present in our practices. Okay. Now this is a case that was in Southern California. 39-year-old with symptomatic fibroids. Many of these patients you may see, I think you've also probably referred a few patients with menorrhagia. Patient went through a supracervical hysterectomy, which we actually don't do anymore, we actually do totals, but this was a while back. Pathology comes up, essentially adenomatous hyperplasia. She gets routine care. Next, 4 years later, colon cancer. 2 years after that, ovarian and endometrial cancer. And it usually occurs in a portion between the cervix, where the cervix and the uterus connect, which is the most common place where Lynch cancers occur. So she had a family history that was taken, but unfortunately, it was never used. Patient was diagnosed with Lynch syndrome after the fact. She died at the age of 49. This case was settled out of court for failure to diagnose hereditary cancer. Again, the standard of care is upon us. So now looking at this is also very similar to the BRCA graphs that you saw before. Again, the main points, which is the most important thing to drive home today, is risk stratification. Positive or negative, these are the risks. So again, you cannot tell the difference between general population and familial risk unless what? You take a family history. How will you tell familial risk, the difference between actual hereditary risk, without doing a diagnostic workup? So again, as a primary care physician, what do you need to know? Increased surveillance and surgery. Refer these patients out if you have a positive genetic result. Super important. And another thing is not to get too nervous about looking at what management of having a positive result is. Everything is very typically cookbook. There aren't any surprises in these algorithms. Do I need this information as a physician? Yes. Overly, resoundingly yes. Do patients want to know? Well, I think the most important thing as a doctor is, of course, you have to have your knowledge, but bedside manner is how you approach and communicate with your patient. If you communicate this information to a woman, she can either be scared to death or actually hopeful that there's something that we can find out about. Patients want to know what can keep them safe. So here's an example of a practice that basically does 96% of testing of patients fulfilling criteria the same day. Now, how can you use this in your office? Over 95% of patients who met guidelines were tested the same day. Most of these patients, now again, the most important factor was that a physician recommended that the test be done was the most important and driving factor that the diagnostic workup was chosen to be done by the patient. So again, the take-home messages, it's not anymore a question of, oh, it's nice to know this information as a PCP. Now it's a need to know because they affect management decisions. So do patients want to know? Yes, they do. Is this my job? Well, a lot of societies are telling us for sure, aside from the fact that we have our moral obligations to do so. So the American College of Obstetrics and Gynecology in their practice bulletins say that it's upon us as physicians to make sure that these risk management models are presented to our patients. Again, regardless of your specialty, you don't have to be an OBGYN. There's something that we can all do for this. So now, even if all patients had access to a genetic specialist, because sometimes physicians would say, like I said earlier, oh, I don't have the time for this. Well, and I want to send them to a genetic counselor. Compliance is a huge issue because the dropout rate ranges from anywhere from 33 to 87%. That deters the ability of both referring and a specialist provider to manage the patient appropriately. So unfortunately, the referral model is a failure, even if we went with a conservative estimate of 50%. That kind of dropout rate can actually have devastating effects on our patients' lives. This is just a busy slide just explaining the prevalence of patients with family histories of cancer. Okay, again, is this my job? Yes, it is. They're repeated reminders for us because I wanted this to be the take-home message, that you can do it in your office every day. It's not just for genetic counselors anymore. Risk stratification is our job as physicians. And we are uniquely positioned to be able to diagnose these high-risk patients. How do I do this in my busy office? Okay, so there are 4 simple steps that I'm sure you're already taking. You basically screen, evaluate, diagnose, and manage. So this is basically my protocol. So my screening in my office. All of my annual patients and my GYN patients get a cancer family history screening form. Usually the first step involves this questionnaire. This questionnaire has been an absolute hit in the office because, first of all, it's great for me as a physician because I get age of diagnosis, relatives, maternal versus paternal, and it gives me a bird's eye view right away as I'm going into their room. So that's the screening part. Diagnosis. There's also, at the bottom of my questionnaire, a little cheat sheet. And this is my cheat sheet, so I don't need to think about this every time to see if my patients qualify criteria for getting this diagnostic workup done. That's for Lynch syndrome. This one was for the BRCA testing. And how do I do this in my busy office? You take and you use the history. Are all the tests the same? Well, basically, what needs to be out there is that data needs to be presented, publications from whatever laboratory you're using. I have worked closely with Myriad for many years, even from the East Coast, from New York. You need to know what the sensitivities are. You need to know what the specificities are. You are clinicians. Not only do you have a liability to yourself, but you also have them to your patients. You need to know what your false negative and your false positive rates on these results, because these results are what you're going to use to manage your patients. Availability of the BRCA testing. So there is a myth out there that this is not a covered test, or that this is something that, oh, my patients are not going to get covered. No, that's not the case. There's actually an average out-of-pocket cost, and this is important because I know this always comes up when you offer this test. Usually less than $100. Medicaid covers it 100%. And other patients, if there's a maximum cost of maybe $375, can even work with payment plans. But this is something that can be done. This is not an impossible test to get. A significant number of patients meet criteria for multiple syndromes. Dangerous myths which are now dispelled. We do need to know. Our patients do want to know. We can do this well and have a specialist support for consultation and referral as needed. We can integrate this into a busy practice. And all tests are not the same. Any questions? Yeah.
My understanding is that Medicare will only pay if you have a personal history of breast cancer for breast cancer. Kind of explain this.
No, Medicare is actually better in coverage now, and if you work with the right, another thing, it's not only personal history, because there's actually California state law that also says that they cannot be denied that testing. So I think it's called the GINA law, and there's another one. So if your insurance companies are giving you this, they need to be presented with that, because they cannot refuse that testing. Okay.
Myriad.
Myriad, yeah. Yes, it is. Yes.
Is it a saliva test? Or?
Yes, it's a saliva test. Saliva and blood, there's both. I'm sorry, I didn't get that.
Is it worthwhile to test the family member as opposed to the patient?
Who has the affliction?
You know, I'm thinking about a woman who comes in and has a pretty significant family history of breast cancers, and she's quite concerned.
She should definitely be tested.
But let's say her mother's still alive and she had the breast cancer. Would it make more sense because of less
Absolutely,
stress
the mother.
to have the mother tested instead?
Yes, the mother should be tested first, because if she's negative, then obviously
Right.
it's not going to pass on. Mm-hmm. Okay. Great.
So it does skip. So say my mother is negative because she has been tested for this gene, so it doesn't pass on to me then?
Correct, because it's
Okay.
genetic.
Okay.
Right. Mm-hmm.
Yeah.
Oh, definitely. We do not ignore the dad.
But the father doesn't have the breast cancer, would you be father's sister and breast cancer?
Then the patient should be tested. Absolutely. The father can also be tested, yes. But a lot of the times it's very difficult, so you have to really, because you have to judge and gauge each situation. Will the parent be involved? Are they accessible or not? So that also determines who and can be tested.
Your breast cancer risk, are you doing the Tyler-Cuzick?
Yes. Yeah, you do the Tyler-Cuzick when they come back, because then you can have an actual familial risk assessment and actually their lifetime risk. And then depending on that, that's when you, if you would like to order an MRI, if their risk is over 20% by the Tyler-Cuzick, then no insurance company can deny that.
What BRCA tests do you ask for, and does the lab then do any subsequent testing? Because I know there's secondary tests.
Yes, I use the Myriad laboratories, and they do the BRCA1 and the BRCA2 sequencing. And then for Lynch syndrome, there are actually 3 sequencings that they do, which is a different test. And if something is positive, then it goes further.
Can you just explain the Lynch syndrome testing more? I'm not familiar with that.
Okay, with Lynch syndrome, it's basically a family history of colon cancer, and there's a relationship to endometrial cancer. So those are the 2. So BRCA is basically breast and ovarian, and then Lynch, endometrial or uterine and colon cancer. So those 2 are related.
And what are the tests that you're associated with
For Lynch, it's called a Calaris testing. Yeah, it's basically, that's just the name for the testing, but it's sequencing the MLH. There are actually 3 sets. I think it's MYP, MLH, and 1 other gene sequencing that's tested. No, currently right now it's saliva. But now what they're doing is that because there's such a similarity between an association between BRCA and Calaris, a lot of patients are qualifying criteria or meeting guidelines for both, so we're doing them by blood. Mm-hmm. Okay.
Thank you very
That
much.
it? Great. Thanks, guys.
Well, it's been a really great day, and I appreciate and thank you for your attention and your probing questions, and I hope that you take away a lot of new information from our symposium. I hope to see all of you this evening at the dinner. Cocktails at 6:30, and then dinner at approximately 7:15. And otherwise, go out and enjoy the beautiful day. Thank you very much.